Over the past year, I have been on quite a journey. I am happy to say I am currently down 43 pounds. I have more energy than I've had in years. My libido is happy and healthy, and I finally feel like I'm coming back home to myself. But it wasn't always this way. For a long time, I think too long to mention, I struggled with depression and anxiety, and I didn't even realize those were two of the more than 80 possible symptoms of menopause. Like so many women, I thought I just needed to push harder, eat cleaner, or try a new workout. But no matter what I did, something still felt off. And that was until I discovered hormone replacement therapy and began getting real answers. Welcome to Nourish with Michelle Fox, your guide to living a vibrant life after 40. If you have ever struggled with consistency in your self care or felt confused about how to truly support your body during this season of life, you are in the right place, my friend. Over this 8-part series, you'll hear inspiring, educational, and real conversations designed to help you nourish your mind, body, and soul so you can feel strong, confident, and fully alive. I am thrilled to share this 8-part series with my guest expert, Kimberly Cunningham. Kimberly is a board certified nurse practitioner who has been serving Colorado for over 20 years. She brings a wealth of experience from emergency medicine to internal medicine to healthy aging clinics. And she's the founder of Cunningham Clinic. After recovering from a life-changing injury through hormone replacement therapy, Kimberly has dedicated her career to helping people look and feel better through functional medicine and aesthetics. She's also a published author, a faculty member at multiple universities, and a national trainer for Biote Medical and Allergan Aesthetics. Her passion shines through in every patient she serves. And before we dive in, I want to share an important note. I personally seek treatment from Kimberly at Cunningham Clinic, but nothing in these conversations is meant to diagnose or treat you. Please consult your own provider before making any medical decisions. So, let's talk about what it really takes to thrive in this chapter of life. Welcome back.
Thank you.
Thank you for joining me because this is one of my very favorite topics, even before I got all fixed up by you. We're talking about sex today,
Yes.
which I am thrilled because we're going to learn some of the science, and we're also going to just answer a lot of the questions that I've been asked, like in the quiet rooms or the text or in my DMs, and things that your clients, what you're willing to share. I can't wait to hear some of these conversations women are having so that ultimately none of us feel alone and all of us know that there is help and that
Yes.
not only do we not have to suffer, but we get to have a lot of fun. Like, this is a
Absolutely.
fun episode. Let's just jump right in. Let's talk about sex after 40. First of all, is that a thing or is that just a tagline? Does sex really change around 40s?
Hormones change,
Okay.
and that will change libido and response and lubrication and the structure and the mechanics of sex, but also a really lovely mental shift after 40. So which one do you want to dive into
I
first?
know. I'm like, all of it? Can I just have all of it? Because as you're saying that, I'm just thinking back to my like sexual awakening. I don't mind sharing. I actually blogged about it for years, but I had this spring awakening in my early 40s where I was dating, I was flirting, I was putting myself out there. I got my body together, like I was working out, I was eating right, like I felt like the shit. And I had a lot of fun. And so there's first marriage, there's that sexual freedom section. And now I'm in this very rich relationship with a husband who knows my body inside and out. And we have the trust and we have an amazing sex life that's had ups and downs, mainly due to the hormones. But as you're saying that, I'm like, I can see myself in all of that, like the mental part of that, the hormonal part of that, the relationship part of that. So let's see. How about let's start with the science part
Sure.
first, just because that's the part where I can trip up and I don't always get into it. I'm more of the touchy-feely, I guess literally, right? Appropriate to the subject. But yeah, I guess the science of the hormones around sex. What is happening right around our 40s?
So around age 35 to 40, and it's earlier in the United States than it is in our European counterparts, women's testosterone starts to fall. Men don't typically lose their testosterone until closer to age 50 to 55. It's also believed that's one of the reasons why men don't look like they're aging until they hit their mid 50s, where women start to look like they're aging by the mid 30s to mid 40s. It's not fair.
Right.
Because as men age, they get ruggedly handsome.
Thank you. And the whole salt and pepper look. Right. Oh, that's so rugged and sexy.
Yeah, we need some of that to be gentler on our side, but
yes, please.
Society being what it is. So hormonally, testosterone literally starts to fall off of a cliff. Without testosterone, we don't have pelvic floor integrity. So people think about atrophy, like withering. Muscles atrophy. If you've ever broken a leg or broken an arm, they take off the cast and what's left is very small and it comes back. Because when you're younger, you have testosterone and you can build muscles. The pelvic floor is a collection of muscles that act like a sling to hold everything in underneath. As testosterone falls, that pelvic floor will atrophy. It doesn't come up and in, it actually falls down. The clitoris then gets enveloped up into that falling pelvic floor. And if you can't get to the clitoris, you can't stimulate it. And there go your orgasms.
And we're not going to have that.
So we need testosterone.
We're having orgasms with the sex, ladies. Period.
And testosterone is sexual quality. So testosterone is nerve health. It's vascular health. The clitoris is an erectile tissue. Just like the male penis is erectile, the woman's clitoris is erectile. And so blood needs to flow into, that's testosterone. Nerve endings need to be healthy, that's testosterone. The pelvic floor needs to be tight so that the clitoris is presenting in a normal anatomical position. All of that is for sexual functionality. When I start women on testosterone replacement therapy, every now and then I'll get a call saying, I think I'm growing a penis.
I think that's even in your book. I remember hearing that story.
I'm growing a penis. It's that pelvic floor tightening up so the clitoris can come back out. I was giving a talk once and a woman in the back yelled, "That's where it went."
Yeah. No. That's where it went. Yes. Oh, and related. That actually is some of the side conversation I have with my girlfriends who newly get on the hormones. They're like, wearing my jeans, I feel a little something down there. I'm like, that means things are working.
And that's not permanent. That's just as the pelvic floor is tightening up, as the clitoris is presenting itself, that can be a little distracting for a week or two and then becomes normal and very fun. So testosterone falling off is associated with sexual dysfunction because of blood flow and nerve endings and libido and muscle tone and position. Testosterone coming back on board is associated with all of those things in reverse. I like to say that hormones are like a country western song in reverse. You get your house back, you get your spouse back, you get your sex drive back, you get to have your orgasms back. When we age after 40, between 40 and 50, we also run the risk of some estrogen dominant and ovulatory cycles. We talked about that in the first episode of what can go wrong in this perimenopausal. So sex after 40 mechanically can become problematic because we're losing our hormones. It can also become problematic because we have an excess of estrogen, which causes its own set of issues that we talked about in the last episode. So the technicalities of sex after 40 can become problematic. So it's important to address those. But on the flip side of that, after 40, women in general settle into themselves.
Yes.
And sex after 40 is not necessarily about procreation anymore.
Correct.
It's about fun.
Correct.
We're one of a few select animals on the planet that has orgasms for fun.
There you go.
And we like that. And so women after 40 are turn the lights on. Get the toys out. Talk about what I want you to do instead of being quiet. Because it's a confidence. I want you to do this. I want to do this to you. These are conversations that begin to really flourish. And all of that is empowering and satisfying and fun. And women in their 40s really come into that. So it's especially a good time to make sure that hormonally we're giving her exactly what she needs so that the body can match what the brain wants to do.
Yes.
Yeah.
Including, I would add, the confidence that a lot of us are getting in our careers at that age as well. I think at that time, a lot of us in our 40s are discovering who we want to be in the world and having and building the friendships that are there that are also building our confidence. And so to be able to have your hormones in check, in addition to all that, we're unstoppable.
And then if you look at women in their 50s, now it's really, I'll start with the bad news.
Okay.
The bad news is that neurological sciences have proven that women who go through menopause who do not get hormone replacement therapy can lose up to 27% of their cognitive computational capacity.
Got it.
And they might not get it back.
Oh.
So that's the bad
Like
news.
even with hormone replacement later.
If you do it later, you might not get it back.
Oh.
So women actually go through a brain drain because of menopause. It's not made up. It's not in, it actually is in their head, but it's not an imaginary in their head. It's a legitimate in their head. It has to do with neuron connectivity and neuron firing speeds and different things that hormones support. And when you just take away those hormones from women, men have a slow decline. Women go through menopause and that's it. And so that quick, rapid withdrawal can often lead to this up to 27% computational decline. So we definitely want to make sure that hormones are balanced. We talked about in episode 1 how they're safe to do. But here's the good news.
Yes, I'm leaning in.
So women over 50 have this amazing ability to calmly look at every level. Our younger selves and our younger coworkers can't do this. Younger workers are driven a lot by their amygdala. So the amygdala is the emotional center of the brain. It's the toddler in the sandbox in your brain.
Okay.
It's the, oh my God, I'm going to panic because this thing didn't go perfect, or I'm going to panic because something isn't perfect or right or real or imagined.
I have 2 18-year-old daughters
Yes.
right now, so this is feeling very real right now. Yes, okay.
So there's the real or imagined disaster that
Yes.
the amygdala drives the bus. When women are over 50 and hormonally supported, they don't lose computational capacity and they are much better leaders. This is definitely proven in different longevity studies. So women over 50, what I mean by being a global perspective in the workforce or even in relationships, they are the best leaders because they can think about how is this system functioning, as well as how is this individual task getting completed, and all the layers in between. And they're bringing with them decades of experience, as well as an amygdala that's no longer driving the bus. So they're not going to panic. They're not going to make rash decisions. The decisions that are made are very well thought out. And what you find is women over 50 are the best at conflict resolution.
Yes. I would like to pat myself on the back for that one. I
Because
agree.
they don't panic.
Correct.
First of all, they've seen worse.
Correct.
Let's just throw that out there. But their brain is uniquely wired at that point to look at things rationally with years of experience and in a way that can actually fit every individual in that conflict's needs. A younger person cannot do that.
I think you just healed something in my family just now. Oh my Lord. Thank you. Because yes, the 18-year-old girls right now,
18-year-old you
they're
could
just
do
off
that. 18-year-old me can't
the
do
grid.
that.
Yeah.
You can't.
Whereas, yeah, I come in
different.
and I'm like, let's find a solution that's a win-win for everybody in the family. And then, at work, let's find a win-wins. Like, to me, it just feels so natural. Whereas a lot of people, it's like, no, me, I need this, me. And I'm like, oh, that makes sense. So it's not necessarily a hormonal thing.
So we spend a lot of time, those of us that had kids and those of us in healthcare, we spend a lot of time learning these different developmental milestones. So Piaget is the most recognized developmental psychologist for different stages. So there's object permanence and trust versus mistrust. And there's these different things. That's why elementary kids don't really get jokes unless they're concrete.
See, I might be an elementary kid then, because I normally don't get any of the jokes.
Well, they only get knock-knock jokes. But if it's
I do have jokes.
But if it's nuanced, that really needs to be more in the theoretical world, and that's going to be later adolescents and early teenagers.
Okay.
And then so there's all these different, we won't go through the stages, but the last thing to come online is something called the prefrontal cortex, and it's literally a part of the brain. It's a structure of the brain that doesn't exist until about age 18 to 22 in females and about age 25 in males.
Okay.
which is why college-aged males typically make very poor decisions when it comes to consequences of actions, because they're missing the brain structure.
They literally just don't
To
have
have
the
consequences of
software
actions.
to, yes, okay, got it.
And then
Got
that
it.
is where the world stops. There are more cognitive stages. And this really beautiful one happens around age 50. And in a mature mind, that's where the amygdala starts to really take a back seat, and this thoughtful, wise problem solver emerges. It's a beautiful thing that our society, unfortunately, hasn't really celebrated. But if you see other societies, they do celebrate the wise elder.
Or the crone, I know,
Yes.
and like a lot of the Latin.
And we are losing out on this resource because we haven't spent enough time celebrating and cultivating it. So yeah, this beautiful thing happens around age 50.
We get to celebrate her right now, the
That's right.
50 plus woman and
That's
her
right.
sexual life. So it's a developmental thing. And then as far as when hormones come in, and my friends who haven't listened to episode 1, please go back so you can hear a little bit more details around that. But can you tell us just a quick 30,000 square feet, what's happening with the hormones as far as the sex hormones? So progesterone, estrogen, and testosterone, right?
Yep.
Those are the three that
Those are the three.
Helping me have amazing orgasms right now, post 50.
All three are important.
Okay.
So let's talk about what each one does.
Okay.
So we touched on testosterone a little bit already. Testosterone, by the way, testosterone replacement therapy was first designed for women, not for men.
Testosterone.
Testosterone pellet-based therapy was originally designed for women.
Did not know that.
Yes.
Okay.
So testosterone, women need testosterone, men need more.
Got it.
Men need estrogen, women need more. So we both need our hormones. We just need them in different ratios because of the different genders. By the way, do you know where the testosterone receptor site is on the chromosomes?
My choice is either X or Y, right? Well, then I think I choose Y because that's male typically, right?
X.
So even the female
X.
Wow.
So the testosterone allele is carried on the X chromosome. Men have 1, women have 2 traditionally.
Got it.
Yeah.
That would make sense. Why
everybody
so
needs
natural
testosterone
in my body. Okay.
Everybody needs it.
Okay.
Testosterone is muscles. It is your libido. It's your ability to have the clitoris attain, and maintain an erection. The clitoris is erectile tissue. We need blood to go into it for that erection to happen. After orgasm, the external sphincter releases and the blood comes out of it. Just like in a man, just a slightly different configuration. So testosterone is clitoral engorgement, clitoral innervation, pelvic floor integrity, sex drive, muscles. Also, testosterone is the most powerful anti-inflammatory.
That's right. Okay.
So when everything hurts and you feel like you're dying,
yes,
you don't want to have sex.
No. Why would you want to put yourself through pain?
And by the way, I have this question that I ask women, and I don't even need to get their labs, and I already know their testosterone is low. I say, okay, it's the end of the day. Okay. And you're in bed, and your partner's next to you, whom you love very much. And you have choices. You could watch TV, you could have a cookie, you could have sex. And you have an order. If sex is at the bottom, you don't have any testosterone.
Oh, it just breaks my heart.
So that's
especially because I've been there. Yes. Yeah, no thanks. I want a cookie while I'm watching TV in the bed, snuggling. I'll snuggle with him, but I don't want anything touching there because it hurts.
So testosterone is the drive and the mechanic.
Testosterone.
Estrogen.
Okay.
Estrogen is the highest at ovulation, the lowest at the menstrual cycle. In a premenopausal woman. Yes. In a postmenopausal woman, there is no estrogen at all. Got it. Because the ovaries have stopped making it. In the absence of estrogen, the lining of the vaginal vault thins, and it becomes so thin that any penetration feels like broken glass. Oh, so that's what was happening then. It's excoriative. So I was without estrogen then. Is that why it felt like broken glass in my pelvis? It's like wrapping sandpaper around a sexual toy and inserting it. Yes, that's exactly. Oh, so I take it other patients of yours have shared the story with you. I had a woman tell me once that it was the Sahara Desert when she pointed to her lab. I'm telling you, it's the Sahara, is what she told me. Yeah, I can. So without estrogen, there are no vaginal secretions, but more importantly, there is no tissue integrity. Okay. So without estrogen, that's why we get wrinkled skin. Okay. And that's why we bruise really easily and our skin can tear really easily because our tissues all get very thin and fragile. Okay. Additionally, without estrogen, chronic urinary tract infections become an issue. Got it. Because the urethra on a woman from the bladder to the outside is maybe an inch long.
Oh, wow.
On a man, it's the length of his penis.
Oh, wow.
So on a woman, it's only an inch.
Okay.
And so when that external sphincter where the pee comes out becomes really excoriated and irritated, E. coli can just become colonized there. And then it's just in the bladder all the time. So even in women who don't want to be sexually active, estrogen is a fantastic thing for them. But estrogen gives us juicy vaginas, really nice plump tissue.
Yes, please.
Because fragile tissue can't be interacted with even if there was secretions. That's why the coconut oil and the Vaseline and the lube, it doesn't work because the tissue is too fragile.
Too fragile, yeah. Oh.
So even if you get enough slip and slide for sexual penetration of the vaginal vault, the tissue is still going to tear because it is so thin and fragile.
The good news
is estrogen fixes all of that.
Yes.
So we need estrogen in the vaginal vault. And in a woman who cannot have systemic estrogen for whatever reason, maybe she's had an estrogen positive cancer in the past, maybe she's gone greater than 40 years without estrogen. I have a couple of those patients. Estrogen protects the brain against Alzheimer's by regulating tau protein synthesis in the brain. It's one of the proteins in your brain.
Okay.
In the complete absence of estrogen in the body for greater than 25 years, that tau protein can become misshapen. And now I don't want to replicate it for any reason because that might hasten the onset of Alzheimer's.
Sure.
So if we can start estrogen replacement therapy right away after menopause, great. If somebody walks into my clinic and it's been more than 25 years since she's had estrogen, I don't want to give her whole body estrogen.
No, that would be way too much.
But I can give her vaginal estrogen.
Okay.
So I can put estrogen just in that vaginal vault.
Okay. That'd be a cream.
It'd be a cream, or there's little pellets that I can prescribe as well.
Okay.
The tricky thing is I have to remind her that's not lube. That's for after sex, not before.
Oh, okay.
Because if her partner is a male,
but he'll be getting estrogen.
Yeah, transpenis infusions of estrogen aren't good for sexual activity.
Yeah.
That he shouldn't have that.
Okay, yeah, it doesn't sound good.
That would be more than he. So what's interesting is in the vaginal vault, it doesn't go anywhere else.
Okay.
Yeah. So
but in that case, then would you work her up eventually that she could have full body estrogen? Oh,
no,
so
not
then
if
once
it's been
it's on,
25 years. Yeah, it's just not safe.
Okay.
But I can give her vaginal estrogen.
Okay.
If she was worried about her skin on her face, we could do a little topical on her face as well.
Oh, yeah, great.
Which most women do anyway, whether or not you.
And that just plumps up the skin, or?
Yeah.
Oh, okay.
Yeah. Estrogen helps with tissue thickness. Thicker skin means less wrinkles.
Beautiful. Yes, please.
Using topical estrogen does the same thing as systemic estrogen in the labia, in the vaginal vault, and again for that urethra. So I can do vaginal estrogen for someone who has chronic urinary tract infections. And it's a great product. It's a great product. So estrogen is the juiciness and the tissue integrity.
Okay.
So testosterone is the structural integrity. Estrogen is the soft parts.
Okay, which tracks.
We want all the parts.
Female.
And then progesterone. So in a woman who has a uterus and is postmenopausal and getting estrogen therapy, we want to make sure that the endometrium doesn't get too thick.
Okay.
Because the good part about menopause is no tampons. So we don't want to have postmenopausal bleeding. So we need progesterone to keep that endometrium in check. And that's a pill taken at night. Now, progesterone is also good for joint juiciness. So people who have creaky joints, they love their progesterone. Progesterone is also how we sleep. So it's really good for your circadian go to bed rhythm.
Okay.
And progesterone helps with sex drive. Well understood.
Please tell us more than I did not know that.
In women who don't have a uterus, if we put them on testosterone and estrogen, and we don't need to do progesterone because they don't have a uterus.
Okay.
But if they don't quite get the sex drive back that they wanted, I'll give them a little low dose progesterone. There it is.
Really?
Yeah, it's nice.
So I guess I'm still confused though, because if you don't have a uterus, and by the way, I am on the progesterone right now, and it does help my sleep, but I didn't know it was also helping my sex drive. Is that because it's keeping these other two in check a little bit?
We don't know a lot about why progesterone helps sex drive. We just know that it does.
Okay.
Sometimes we say, that's okay, we're just going to do with the thing that works.
Exactly.
There's so much, by the way, in healthcare that we know it works, but we don't know how.
Sure.
So SSRI, selective serotonin reuptake inhibitors, which are the #1 class of antidepressants written in the United States. By the way, nobody looked in your synaptic cleft to count your serotonin molecules before and after an SSRI. We just know theoretically how it works.
Got it.
But nobody's actually checked in a live human. Because
you probably can't. It's way too.
So it's theorized that's how it works.
Okay.
But we don't really know. So
but
one of the most common medications prescribed is a mystery.
Interesting.
Most of it's theoretical. You can prove some things in rats and mice, but it's hard to prove in people.
Ugh.
I'm very open with
What?
this is how we think it works.
Yeah.
But we don't know.
Which I so appreciate. You're helping
But
us
your
like
body
peel the
made
curtain back.
progesterone in the second half of your ovulatory cycle
Okay.
up until menopause.
Right.
Right. So
it's like
giving you bioidentical progesterone is healthy.
Mm.
It's good for you. It's safe for you.
whatever you're doing, keeping me feeling like I'm 35, we're just gonna keep doing that. Yes, please.
So those are the 3 hormones to balance.
Okay.
To make sure that the brain and the body and all of the things involved in sexual wellness are working.
Okay.
There are other things we can do.
Tell me more.
There are procedures that
Okay.
you can do. There's something called an O shot, which
Okay.
is also known as the WOW shot or the G shot.
Okay. I'm guessing this is just for females.
Yes.
Okay.
For men, it's called the P shot.
Okay.
Men also have different names for these. So different physicians over the years have come up with different injections of either PRP or exosomes to stimulate more nerve ending and blood vessel formation.
Okay.
In men, we can also use a Z-wave, which is a pulse wave device to cause neocollagenesis or the formation of new blood vessels to the penis. So there's different things we can do for men. But in women, there is an injection series that can help stimulate blood flow and nerve ending growth into the clitoris.
Oh.
So the
Okay.
clitoris is actually bigger than most women think.
Tell us.
There's the part that feels like your nose that sticks out in the front. People call
Okay.
that the clitoris. That's actually the glans clitoris.
Yeah.
And then it goes inside the body.
Okay.
There are legs and bulbs that go around the vaginal opening. Everybody calls the clitoris where you put the vibrator.
Okay. Yeah.
But there's more of it that goes inside to the vaginal vault. That's where the G spot is, and then the legs around the vaginal opening. And so in women who we've done hormone balancing, and we've given it time, because Rome wasn't built in a day. We have to build blood vessels and we have to grow nerve endings, and nerves grow about a centimeter a month.
Oh wow.
So if we're coming off of the back and we need to get around the pelvic floor,
Yeah.
or from the front to the clitoris, we need a good 6 to 8 months to make sure we've had enough time.
Okay.
And then if we don't have as much return to sexual function, I will do the injection series.
Oh.
It's where we draw some blood, spin it down, separate it, add either a biologic to it or just keep it as the blood, depending on different practices, do different things.
Okay.
And then we do the injection series, and that is a wake-up call. We're not done yet. We're still using this body part.
And
we want it to be working.
And this is on top of the HRT that they're doing.
So
I'll
do these about 6 months after starting HRT if she still hasn't had enough return to sexual function. And then
and there's a shot right there on her vagina?
Yep, so it's right and left opening of the vagina between the Skene's glands and the vaginal opening.
Okay.
By the way, the Skene's glands, these tiny little openings left of the vagina, is where female ejaculation occurs.
Oh,
yeah.
Okay.
Women actually can have female ejaculation. And then I will do an injection point suburethral, which is inside the vaginal opening, but just along the urethra. Okay. That stimulates the G spot, which is deep in the vagina and then closer to the belly button. And that is where the urethra comes off the bladder and the clitoral legs come off. And so most women, when they're having their G spot stimulated, feel like they have to pee a little bit. Yeah. Because you're actually hitting that urethra.
Ah, that makes so much sense. I always wondered. Okay, yes. Got it. Yeah.
So I'll do a suburethral injection point. It helps with G spot engorgement, as well as sphincter tone along the entire length of the urethra. Perfect. So it helps with bladder control. Perfect. And then I will actually inject the glans clitoris, which is, again, that feels like your nose right in the front where you put the vibrator. I'll inject there because that is the largest collection of nerves for the clitoris. We want that to be the most excited.
Yes, please.
And the most responsive to these injections. Yeah.
Love that.
So we get the whole, and I do a nerve block first, so it's not very painful. The suburethral one will get their attention, but it's 5 seconds.
And that's worth it if you get pleasure.
It lasts for up to 2 years.
Just the one shot. Wow.
Yeah.
Oh, I love how far science is coming.
If the hormones are there. Because this is a stimulus to say grow nerves and grow blood vessels, which you can only do if you have testosterone. And this is a stimulus that says repair tissues, which you can only do if you have estrogen. So we always start with the hormones. And then if we need to, there are more things we can reach for. There's also vaginal rejuvenation.
A little bit more about that. I've heard like stories and things on TikTok about that, and it makes me very nervous. But
Sharon Osbourne, and we just lost Ozzy. But Sharon Osbourne, I think she was the first one to publicly talk about vagina tightening surgery publicly.
Yeah.
Yeah. I think it was the Graham Norton show. Should have seen his face.
I can only imagine. He's like, we need to talk about that right now.
Yeah. I don't think anybody had talked about it publicly before her, so God love her for talking about this.
Yeah.
The vaginal vault can become atrophied, which again could be a tightening, withering, but could also be a flaccid loosening
Because of loss of estrogen.
because of loss of testosterone and estrogen and how much time they've spent in the hormone desert, as well as you can have large baby, small person. I think she's 5 feet tall.
Yeah.
They have 3 kids. So if you had big baby, small vagina,
sure,
that can cause trauma.
Sure.
So sometimes surgical interventions are appropriate. And so going to a pelvic floor subspecialized reconstructive surgeon would be appropriate. There's one that I recommend here in Denver when we need to have reconstructive surgery. There's also new radio frequency devices.
Oh, okay.
So microneedling with radio frequency came on for aesthetics to tighten up skin.
And your clinic does that as well?
My clinic does that for faces and bodies, but not for vaginas.
Sure. There's definitely a distinction there.
When we started doing radio frequency for vaginal and labial tightening, because sometimes the labia, the minora and the majora get too big, and then that's an impediment.
It's like hiding the clitoris, right?
No, it's getting pinched.
Oh,
the labia is too big.
Yeah, that took me a second. I told you with jokes and things like this, it takes me a minute, but once I get it, I'm like, oh, okay.
So if the labia are getting pinched,
ouch.
That'll end things for a moment, perhaps the event.
Absolutely.
So when it comes to labial rejuvenation or vaginal rejuvenation, when we're reaching for energy-based devices, I want that woman in front of a pelvic floor reconstruction board certified subspecialty surgeon, because there might be other issues going on. And there might be pudendal nerve dysfunction. There might be some other things that really they need to be with a specialist. And that's where I definitely say, no, Dr. Bruce Dorr at Littleton Gynecology and Wellness is who I send people to in Denver. He's brilliant, the nicest man. He and his wife are just lovely humans. I know them both personally as well as professionally because I refer patients to him all the time. But he does non-surgical, which is the energy-based rejuvenation. And then he also does the surgical.
Okay.
And so he's really the best equipped to decide, okay, this one's surgical. This one we might be able to do an energy-based device. He is the pelvic floor surgical expert. Perfect. And I'm happy to have him be the expert in that.
There you go. Yes. I'm like, I think you and your clinic do plenty.
The actual injection, the PRP for vaginal rejuvenation, that in the injection series is very safe, very simple, very straightforward, and I do those. Yeah.
Ah,
yeah.
Beautiful.
Lots of different ways to get things juicy, tight, and ready to go. How's that?
So anything else about how sex changes after 40 before I move on to the next question? I want to make sure I don't miss anything.
We talked about mechanically what can change. And I just want to remind people that before we go from perimenopause to postmenopause, fertility is still available.
Yes.
So when we reach for birth control methods from age 40 to 50, and if somebody wants to have a baby between age 40 and 50, great. There's lots of ways to do that safely. Lots of fertility experts are helping women have babies into their early 50s very safely. That's fantastic. But if that is not our goal, what we don't want to reach for between age 40 and 50 is combined birth control pills if we can avoid it. Oral estrogen increases something called sex hormone binding globulin.
Okay.
And it does what its name says. SHBG's job is to bind up your sex hormones. Your body always has a way to turn things on and turn things off because we're always reaching for balance, this homeostasis. So sex hormone binding globulin is a way to turn things off. We have too much estrogen, we have too much testosterone. We want to increase SHBG to bind it up so it doesn't work anymore. Okay. Because the receptor sites are getting super saturated. So unfortunately, combined birth control pills, which is like Orthonovum 777 or any of these estrogen and progesterone pills, you take 3 weeks worth and you take a placebo week and then you start over. It's that pill pack. Increases sex hormone binding globulin. Oh. And there goes your testosterone.
Oh, yeah.
And remember, testosterone starts to fall off the cliff around age 35.
Yes.
So if you hit 40 to 50
and
you're on combined birth control pills, your free testosterone likely is zero. Actually zero. Okay. Which means no muscles, no sex drive, no libido. The pelvic floor is falling down. The clitoris is gone. It's all going in the wrong direction. So in my practice, we recommend a progesterone-only IUD not the copper, because that causes a lot of issues, but a progesterone only IUD is fantastic. That's Mirena, Kylena. There's a few options for those, or a medication called Slynd, SLYND.
Okay.
It is a progesterone only. Is no generic. So if they say I'm going to put you on the generic for Slynd, that's a lie.
Okay.
That's the mini pill, and that's called getting pregnant in a week.
Oh, okay,
Right.
yeah.
The
No,
mini
thank
pill
you.
is a progesterone only pill you have to take at the same time every day.
Okay.
Slynd is a long-acting progesterone only birth control pill.
Oh,
It's been available in the United States now for coming up on 3 years,
okay.
but Europe for 12.
Okay.
So
there's
lots
some
of
research,
lots
some
of data.
history, yes.
What's lovely about Slynd is it's not just progesterone. It acts a little bit like spironolactone, so it clears up perimenopausal acne.
Oh.
Prevents DHT conversion. And DHT conversion is how some women start to grow facial hair and have hair thinning associated with menopause. And it runs in families.
Yes.
So
I've seen
Slynd
that.
blocks that beautifully.
Perfect.
You get very little bleeding, if no bleeding,
Okay.
because it's progesterone, so it's going to stabilize and thin that endometrial lining beautifully. Women with endometriosis don't have any issues because you can't give them estrogen because it flares their endometriosis.
Yeah.
So Slynd is a long-acting progesterone only pill.
Okay.
It is a birth control pill, but there's no estrogen in it. It's been in the United States for about 3 years, Europe for 12. So lots of longevity data on it.
Yes.
So Slynd works great for birth control.
Amazing.
But it also is really helpful for all these other perimenopausal symptoms, like acne, like hair thinning, like facial hair. It blocks all of that beautifully. So if we're looking for a pill, I choose Slynd. If we're looking for the easy button, it's going to be a Mirena IUD or Kylena or progesterone only IUD.
Okay.
So those are really good choices for birth control as well as managing perimenopausal bleeding, because women will bleed for 2 weeks, then not bleed for 2 months, and then bleed for a day and a half, not for a day and a half, and then bleed for a month. So it's all over the place. And it's hormone whack-a-mole that we talked about in episode 1.
Yeah.
The two that I like to recommend for birth control and to fix this perimenopausal bleeding issue is either a progesterone only IUD or that Slynd.
Beautiful. Thank you. It didn't even occur to me about the fertility piece, because I actually, part of my story is it wasn't a full hysterectomy. It's where they took out my uterus, but
That's
I
a
still have
hysterectomy.
but I have my ovaries.
That's called an oophorectomy.
Oh, okay. I had that.
So it used to be called partial hysterectomy was the uterus, full hysterectomy included the ovaries.
Got it.
And now they've just divided the nomenclature to where hysterectomy is just the uterus, oophorectomy is the ovaries.
Okay, got it.
It's fine.
So then I bypassed a lot of the perimenopause
All the
typical
bleeding.
symptoms. Yeah. So
Me too.
I just had the surgery. And it's actually super cute because I think she was 12 at the time, my 12-year-old daughter, they're like, they removed your asparagus. I'm like, yes, they removed mommy's asparagus is gone.
Oh.
And thank goodness I didn't have to go through the spotting and the bleeding and back and forth. But yes, I've heard these stories. So thank you for sharing that. I think that will clear some things up for some of my friends who are still bleeding.
And I try not to have patients go for hysterectomy if at all possible.
Yeah.
Ablation is better. The uterus has structural support to the pelvic floor in holding the guts up.
And back, I noticed too. Like I had to do some PT because some back muscles.
And then the uterus also is the collateral blood flow across the pelvic floor. And then when we take out the uterus, we take out some large blood vessels. And that could lead to what's called pelvic congestion syndrome or May-Thurner's, where you get these varicose veins across the pelvic floor.
Ugh.
And then we have another problem.
Well, yeah.
So
like,
I have an interventional radiologist center that we send people to if they have that. But if as much as we can, we want to preserve the uterus. So if it's not behaving well, we'll do an ablation first and then we'll go to hysterectomy later. I didn't have an option for mine.
Perfect sense.
But anyway,
I'm totally changing the subject now.
Yes.
I mean, still topical, but in this book that I have recommended to all of my friends, and Kimberly has plenty of free ones that I always grab when I'm in her clinic to give to my friends. One of the things you recommend for those of us in couples is to put sex on the calendar.
Yes.
And that is one of my favorite game-changing advice pieces that I have picked from this book that I've read front to back 3 times already. But can you talk to us a little bit more about that? And actually, before you jump in, I will just share for us, it doesn't mean we're only having sex once a week. It just means that one night we know we get to have that intimacy and we get to have that communication in it. And it's that thing that we get to look forward to that day. And then, of course, other days, it's always an option. But how did you come to that? And how did you come to the knowing that you needed to put it into the book to recommend that to the rest of us?
So when things are important, you put them on your calendar.
Yes.
And I've always been an athlete. We talked about it in episode 1. I trained for different events and I trained for different fitness competitions many years ago. And you would always put your training schedule on the calendar.
Good point.
Because I'm going to do that.
Yes.
Because if I want to get
Yes.
to here, I have to put these things on the calendar and make them happen.
Yes.
If I want to have a healthy sexual relationship with my partner, for me, it's my husband. If I want to have an intimate relationship with my partner, my husband,
Yes.
if I want to have these things, they can't be last on the list.
Exactly.
My marriage is the foundation of my family.
Yes.
It comes first.
Amen.
And when we became married, it was really interesting because people didn't protect the sanctity of this new family that we had created until we started having kids.
Interesting.
And
how did that show up? What do you mean?
I protected it from day one.
Would people like invite you to things you didn't want to go to? What do you mean by they weren't?
No, it didn't change until we had kids for who's going to go visit whom for holidays.
Oh, okay.
And who's going to travel the most
Okay.
or have the biggest effort to put in. And who's going to impede on your time, which is fine. And it could be friends and it could be work and it could be family members. But from going from dating to engaged to married, the assumption that we would be available to do the most work was always there until we had kids.
Interesting.
And I remember thinking, no, we are a family now, which means
yes,
I'm going to check with my husband. He's going to check with his wife before we commit to things.
Very good.
And that always shocked people. But as soon as you have kids, oh yeah, you have to check because you have other responsibilities. No, we have a responsibility to each other and to the foundation of our lives, which is our marriage. And so it's important to us to always be married. It's important to us to always be in love. It's important.
Yeah, yes.
And so because it's important, it goes on the calendar.
Yes, amen.
And you don't have to say, get your freak on sexy time on the calendar, especially if other eyes are going to be looking at the calendar.
You have special ways
So
to do
have
that
a code word, have it be whatever the code word is or something fun or a business meeting or it's the family meeting or whatever it is.
We use emojis on our calendar.
That would suit. You might figure that one out. So it's important. And important things go on the calendar.
Yes.
And I talk about it in the book, and it's important it goes on the calendar. And sometimes women like to get ready for sexy time.
Yes.
You're going to do your wax on this day. You're going to do your hair on this day. You have plans.
Yes.
You're going to shave at this time. And you want it to all work out just so. It doesn't mean spontaneity is gone. It doesn't mean that other days are off the table.
Correct.
It just means that you feel really good about this one.
Yep.
You might time some things for that. Great.
Absolutely.
So when we get a spray tan, great.
I love it.
Whatever you need, it's all planned. So you feel really good about that connectivity. And then you also don't carry guilt when you don't have connectivity other days.
I love
Thank
that
God
point.
women carry enough guilt as it is.
Yes. For so many other things. Yes. Amen. Thank you for sharing that.
Yeah.
And as a nutritionist, I feel like I'd be remiss not to say, like, on our day that's on the calendar, I'm really clear about not eating a lot of sugar that day. Because I notice when I eat sugar or if I drink alcohol, libido's gone. Like,
alcohol increases sex hormone binding globulin.
Oh,
elevated blood sugar also increases sex hormone binding globulin.
Binding.
So remember
that
it's
literally taking those sex hormones.
So it's taking your testosterone away.
That makes all the sense in the world.
So
okay.
A little bit of alcohol can be an aphrodisiac, but more than one drink is already inhibiting your testosterone. So don't wait too long and grabbing a second drink.
That makes so much sense. Thank you. See, you're continually healing me. Thank you. I needed to know that. Yeah, that makes a lot of sense. Okay, got it.
So yeah, putting it on the calendar is important.
Yes.
Setting the mood is important.
Yeah.
There was a great study out of Germany talking about music and libido.
Say more.
And I referenced it in here, so if you want to go look it up, you can. They actually looked at music that makes you feel sexy. And then you have these different receptor sites in your skin. So you have hot and cold receptor sites, you have pain receptor sites, and you have touch receptor sites. So these touch receptor sites in your skin are 10 times more active when you are listening to music that you find sexy.
That makes even more sense.
So you did a sexy playtime list.
Always insist on music. Yes. Okay. Good to know.
So songs that make you feel sexy and songs that make him feel sexy. And there's different kinds of sexy.
Yes.
There's romantic sexy. Maybe there's a little adventurous sexy. You've got different moods with sexual encounters, just like you have in your life. So maybe you've got a few different playlists, and maybe he or your partner has a few different playlists.
Love that.
And maybe you pick a playlist, maybe you throw them all in there on shuffle and see what happens.
Now we're talking, shuffle it all together. And for those of us with kids still in the house or other roommates or other people in the house, I think music's a nice touch too, at least for me personally. Because when the music's playing loud, I feel like that's the kind of cover noise, and so I don't feel as inhibited.
And also, sex does not need to be a nocturnal activity.
Amen. Say that again.
Kids
Yes.
go to school.
Yes. Yes.
Lots of people work from home.
Yes.
Or can plan a lunchtime encounter.
Absolutely.
You have the house to yourself. Also, kids do sports. You don't always have to make every single game.
Amen. Preach.
Make most of them. Cheer, do the pom-poms, make the beaded bracelets, do all the things. But if there's a whole day sports event, maybe you drive to one and your friends drive to the other, and you each get a day. Because the older we are, the more tired we are.
Yes.
And there's a whole, we could spend a whole podcast talking about sleep and the importance of sleep and waking up at the same time every day and going to sleep at the same time every night. Well, if the house isn't to bed until it's time for you to go to bed, making sexual and intimacy interactions the last thing on the list, you're too tired. So there's daytime sex is great sex.
Preach.
We're all over 40, so we're turning the lights on anyway.
Whoop, whoop. Although it depends. It depends on my mood. Yeah. Oftentimes I'm okay, but sometimes I really just want it dark. Just depends. But I have to say, since I've been on the Precipitide and I'm down 40 pounds, I'm like, I even want to just look at myself. I'm like, there's so many times I will walk by the mirror and I'm checking out my ass. And Steve, are you checking yourself out again? I'm like, yes, I am. I'm like, I'm looking good.
You look good. And you only get one body to live in.
Yes.
So being a good steward of that body is important, and enjoying that body is important.
Thank you. Yes. And I also feel like we've been talking a lot about heterosexual sex. And so I just definitely want to take the pause for the women in our audience who don't want a man in their bed and they are sleeping with women. And they might be saying, I don't need testosterone, or why do I need testosterone if I'm not having sex with a man?
Because sex is sex.
Okay.
And clitoral engorgement and orgasms don't care about the gender of your partner. It cares about functionality, blood flow, nerve endings, and stimulus. So the mechanics of orgasm aren't dependent on the gender of your partner or even a partner.
That part too, yes, from my single girlfriends who are, I have a handful who are on HRT right now, and they're like, testosterone, thank you for the vibrators.
Oh yeah.
Thank you for the hip tips on the vibrators, which we'll talk about in a future
talk about vibrators.
Sure.
I gave a talk at the Second Act Women's Conference. Gosh, I think this is 5 years ago now.
Love it.
And I was talking about testosterone and orgasm quality and the mechanics of sexual wellness in women. And through the Q&A part at the end, discovered that most of the room did not own a vibrator or a sexual toy.
Oh! That makes me so sad.
I literally said to a room full of 100 women, ladies, if you have neither vibrator nor partner and I fix your testosterone, you're going to get carpal tunnel.
Oh. I love that.
Safety first.
Like, it's too much work for one hand.
So we went shopping. I took over 20 women to Fascinations, which is a local store here in Denver.
Yeah.
We went shopping and I got the store manager to be our personal shopper. She took us down the wall of fun and started explaining what the different toys were. And we'll bring them in on another episode and we could talk about this. And it was just the most fun to have these women realize, okay, I get to feel sexy again with my hormones.
Yes.
And I get to go toy shopping and explore and have a good time. What feels good to me is now important. And that's another piece after 40. We stop taking care of everybody else. We can actually start saying, wait a minute, I get to live this too.
Amen.
Yeah, it was really fun to do that.
Love that. I love that you said it's about us, and I'm excited to say our next episode. So please come back for our episode 3. We're going to talk about just redefining sexy and women over 40, and we'll bring it all together. But before we leave, are there any pieces or parts that we may have missed out or that you wanted to highlight?
So I just want to touch back on the sexual dysfunction piece.
Yes.
When sex is not working.
Yes.
And when sex is not working, I'm going to encourage everybody at home to write down exactly why it's not working.
Okay.
Is the vaginal vault too dry? Does it hurt? If so, does it hurt with penetration or does it hurt with orgasm, external, internal? Be very specific and exactly why it's not working.
Yes.
Is it a lack of desire or is it a lack of being able to tolerate the activity? All of these things are important because when you write down exactly what's not working, you'll be ready to take that list to your hormone expert. And we said this in the first episode, and I'll reiterate, not all gynecologists are prepared to have a peri and postmenopause discussion about sexual dysfunction. They only 30 to 33% of residency programs in gynecology even discuss hormone dysfunction, and the ones that do have less than 7 hours.
No, so disappointing.
Take your questions to your gynecologist. If he or she isn't prepared to discuss them with you, find a hormone expert that is, so that you are ready to get on with feeling better. And don't be afraid to ask these questions. And don't be afraid to be specific. Those of us that work in healthcare, we've seen it, we've taken care of it, we've talked about it. And if your healthcare provider isn't ready to talk about it, find one like me that is.
Yes.
But that list of this is what's not working is so helpful to get a jump start on getting it back to working as soon as possible.
Yes, because then more specific questions to
Mhm.
ask. And then also, if you're like me, you get into the doctor's office and you just freeze. It's like, I think I had 10 things, but okay, just let's go. But if you have it written down, it's like, no.
Yes.
Here's my list. Here are the things I want to talk about.
I've had women hand me
yes.
their list because they just were so tongue-tied.
Yes.
Once they got in there, they went, nope. And they just handed me the list. I said, this is great. And I went through it. And that let me know where to start and how to help them get feeling better.
And so clearly, I'm sending all my Colorado friends to you. But if we're not in Colorado, where would a woman even start? Like when you're saying go to hormonal therapist, can you Google hormonal?
No, there's not a certification for this yet. I teach for a medical education company called BioT Medical, BIOTE.
Okay.
Medical.com has a find a provider button.
Awesome.
And you can click on that. Now that is someone who has gone through the class that I teach.
Okay.
And knows how to do hormone replacement therapy specifically via the method that we utilize at my clinic as a place to get started. It's a very conservative how to replace the hormones and a very safe way in how to get the labs.
Amazing.
Now that's a day and a half certification class.
Okay.
Which is great.
Okay.
But remember, we had 7 hours and now we have another 12. So depending on how they have kept up and how much they engage in the community that I am in and hormone health and sexual wellness will depend on how nerdy they are about this. If they're like me.
I was gonna say, we like the nerds taking care of our health, for sure.
A really good place to start is biotmedical.com, find a provider, because now you have someone who's vested and interested in wanting to help patients along this part of their healthcare journey. So that is a really good place to start.
Okay, awesome.
Yeah.
So that's our homework until the next episode. We're going to be writing down the things that are working and or not working for us. We're going to be asking the questions, how can we get better? Because we don't want any women struggling. And in fact, we want you enjoying pleasure and having as many orgasms as you want to have.
We're going to put sex on the calendar.
Oh, that's right. Sex on the calendar.
Sex on the calendar.
Yes.
And we're going to make our sexy time music list. We're going to make our list and our partner's going to make their list. And then we're going to decide who gets which playlist on which day, or we're going to throw them all in there on shuffle.
I love that. That'll be my homework.
Those are the 4
between now and the next time. Then, okay, I'll make my playlist. You have my word for it.
Perfect.
And then, of course, and actually, where do we get this book? Can we get this on Amazon?
You can't get that on Amazon.
Okay.
It's available in print or in Kindle Unlimited.
Perfect.
So you've mentioned a couple of times, we give them away at the front desk of my clinic because BioT Medical liked the book so much, they paid for BioT providers to be able to just give it away. So that was really nice when my book came out, and it was a #1 new release on Amazon.
Of course it is, because it's so helpful.
Yeah.
You gave me ideas I didn't know, and you explained hormones in a way that I didn't know.
Half the book is about men. So remember, there's just men and women are both represented in here. We talk about toy shopping for men. We talk about the injections for men. We talk about hormone replacement for men.
That's true.
So it's men and women are both represented in the book for how to make sure that the hormones and then the sexual functionality are available.
Thank you.
Yeah.
Thank you 1 million times.
Happy to be here. Thanks for having me.
Thank you so much for listening to Nourish with Michelle Fox. Were you driving, folding laundry, or maybe walking around the neighborhood? Perfect. I've got you covered with show notes over at michellefox.com/podcast. When you're ready, you will also find resources to support what you've learned in today's conversation, plus a few health supportive freebies waiting just for you. If you enjoyed this episode, it would mean the world if you left a review on whichever podcast platform you're currently listening from. Your support helps me continue my mission of building healthier communities. This 8-part series is my effort to help more women stop suffering in silence and start feeling strong, confident, and seen. I am grateful to be on this journey with you. Big love.